And welcome to this week's episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And we've been waiting for this one for a long time. You know, it seems like every time we get to sit down with these two guys, we never really have enough time.
It's almost like we need a reunion, right? Because
yes, that's right, really John. What it is.
We need a reunion.
That's the right word.
When we were out at Spear and covering what was the thing? There was a Spear Summit, right? And we ran into Gregg and Bob at a after evening function, and they were like, "Guys, when are we going to get on the show?"
Yeah,
and we were like,
"They hadn't gotten a chance to do it together.
We didn't know you wanted to come on,
right?" Yeah.
And so,
and then we got a chance when we were out at our last workshop to actually get them both on at the same time. But it was like over lunch. We had like 20 minutes. You barely kind of get into things on a show like this, until you're in 10, 15 minutes. So we're super excited to bring back onto the show today, both from Spear Education, Dr. Gregg Kinzer and Dr. Bob Winter. Welcome, guys.
Hello. Thanks for having us.
Oh, yeah.
Yeah, good morning. Thank you.
Well, we were talking quite a bit as we've spoken to you guys individually over the last few weeks on a couple different topics. And we kind of had put together some ideas talking with you guys based on what you guys are passionate about to try to have a show to talk about implant materials, implant restorative material selection. And it wasn't just that, it was kind of dovetailing that together with some of the information that, for those of you watching the show, comes from Linkovicius' book, Zero Bone Loss Concepts. And there's some interesting things in there that will maybe kind of fit into the show today. We wanted to kind of get your thoughts on. So let's just kind of dive right in. For most people that are watching the show know who you guys are. You talk a little bit maybe before we get into the questions about which workshops, seminars you guys are teaching out there at Spear. So for those who don't know what you do, you can kind of give them a little background on you guys.
Yeah, start with Gregg.
Thank you again for having us here. It's always fun. I was laughing when you were recalling our conversation at the summit because it's actually true that our feelings were hurt is really what happened. Here you guys were doing it. You got this huge schedule, and then it's like, what the hell? Like, where were we on your schedule? So we guilted you into actually having us on your show.
But the counter argument to it was we really weren't. At that time we didn't know you guys very well, and we weren't really sure if you guys wanted to do it. Because some people are like, because I think a lot of people have the thought of, well, maybe we're going to ask you about your favorite ice cream or something like that. So then once we heard you actually wanted to come on, we were like, okay, so it wasn't personal. It was,
that sounds like a cop out because every other faculty member was on it except us. So I don't know, maybe we got overlooked.
So that's it sounds like maybe you're too shy to approach us.
Maybe that's what it was. Intimidating. Yeah, because Bob, especially Bob, you're incredibly intimidating, right? No, not at all. Tell us, Bob, what you do out there at Spear. What are some of the things you're teaching? And Gregg, we'll talk about your workshops and seminars too.
Well, I'm involved in quite a few of the workshops at Spear. Spend about 90 days a year teaching workshops, so that's about 30 workshops. Everything from preparation, design, and materials to anterior indirect restorative dentistry, implant restorative dentistry, worn dentition, comprehensive case planning and phase treatment, composite workshop. So quite involved with most of the advanced, if not all the advanced workshops, and do recording for online segments, write for Spear, and so do a lot of different things, wear different hats.
Yeah, I'm
Gregg,
pretty much
talk about yours.
Yeah, I'm pretty much the same as Bob. Bob and I do a lot of the advanced workshops together. I also am in almost every seminar that we do. The only ones I'm not involved in would be the airway seminar and the terminal dentition, but everything else, treatment planning, occlusion, worn dentition, interdisciplinary implants, those are all, I'm in all of those. And then treatment planning, the FGTP treatment planning workshop is the only other one that I'm in that Bob isn't in. But otherwise, we enjoy being around each other, Bob and I, even though we were trained at different times in different places. We practiced together for 3 years when I first came into practice. And so we see things and think about things in a very similar way. So in the advanced workshop, like when you guys came in, it's fun for us because you think about things maybe differently than others do. And your questions are fun for us. And that's why we kind of look forward to these podcast with you guys, because you kind of want to get down and dirty with the nitty gritty of the nerdy part of dentistry that some people don't really want to talk about, that you guys want to go there. So it's fun for us.
Good.
Well, good. Yeah. It's rare that we get to geek out, and actually it's been kind of cool because as the podcast has evolved, people kind of know that's what we're about. So we get to bring people on that are in that same vein. And it sounds like that's why you guys get, to enjoy hanging out with each other, is because you're kind of the same way. So with that in mind, let's begin the geeking out by talking about abutment selection. And now we've talked to you guys a little bit about this in the past, for sure, when we've been on together. But one of the things, I want to kind of maybe again dovetail it into the book. What one of the things that Tomas talks about is how we make decisions on the abutment based upon material in terms of biology, as well as, fit, and then talking about emergence. And he's a big fan of using titanium bases versus using customized abutments. And, he talks about in the book that some of that is you get an OEM fit. Some of that is to have the ability to have as much polished zirconia against tissue versus having metal. But, early on, we saw some issues, you guys I'm sure did too, with debonding of these, like the chimney length was real short. It seems like that's maybe getting better, but talk a little bit about what you guys think there. Custom abutments, tie bases for your, for these, especially these screw-tained posterior restorations. What are your thoughts on choosing that, and biology, structure, all that stuff?
Well, I'll just let me start, Bob. His book is actually really it's really well put together, and he has written and thinks and has done research on things to the nth degree, things that maybe a lot of dentists just kind of take for granted or maybe don't even think about at all. So it was very nicely put together in his textbook. You bring up the good point, because you could go, I'm all interested in biology, so that zirconia surface is the most important and every abutment should be zirconia. But then you have to bring in structure, because there are times when zirconia maybe isn't the material because of the position of the implant and the thinness of the zirconia, and then the risk of fracture. So it's kind of a balancing act between, if you have an ideal situation, what is your thought process and what are your material selections? And then if you have to back off because one of your parameters isn't correct, orientation, inclination, subgingival margin or subosseous position of the implant, now you have to reconsider and you have to kind of go a different direction. So the good thing is that there's a lot of abutment materials that we have to choose from, and the way we would choose then would be based on the factors of what's going to be the kindest to the tissue, what's going to have the best fit, what's going to have the best longevity in the mouth with maybe some of the forces that we have to contend with. So it's not just telling your technician, hey, I got an implant, give me an abutment and I'll just put it in the mouth. There's so many factors involved.
Yeah, one additional thought is the terminology used to describe the custom versus using a tie base. Just keep in mind that everything that you use a tie base with is customized, right? So the connection is really the reference that you're referring to, rather than, for example, a UCLA type where you can wax and cast onto a particular sleeve, but yet if you have a tie base, everything above the tie base is customized. And with the evolution of tie bases, you have different not only heights of chimneys today, but also collar heights, depending on the position of the implant relative to the height of the soft tissue. So in my opinion, they're all customized concepts.
So to get back into your discussion, manufacturers have helped us. They've learned through us, I'm talking clinicians now, not us in particular. But you mentioned that the initial tie bases, we had failures. We had debonds because the height of the tie base wasn't ideal, the chimney height. We had problems of seating some of these because the flare of the tie base came off too quick. And if the head of the fixture was a little bit below the osseous crest, you couldn't get it down. Or if you wanted to get it down and you polished off the flare of the tie base, now structurally you have a weaker restoration. So manufacturers have helped us because now we have different heights, gingival heights before the flare starts. We have different chimney heights that we can choose from. So we have a better selection now than we've ever had to be able to use a tie base and then again to have a tight zirconia piece that's customized, as Bob said, on top of that.
So do you think, knowing what we know about the first off the biology side, with having, do you feel like you agree with the idea of maximizing the amount of zirconia, by using a tie base to maximize the amount of zirconia, letting the crown do the emergence, if you will, versus increasing the amount of metal? Because it used to be, the thought was we needed that metal to support our porcelain, right, in order to have strength back when we were doing more layering. Do you think that you would favor a tie base over a custom abutment for, say, a posterior screw retain restoration, knowing what we know now and with all the variability of the sizes and shapes we have?
Well, your first decision would be, if you want to go metal free and you want to go to zirconia as opposed to titanium. Some of the research shows that maybe the best material subgingival is zirconia. And then different degrees of polish comes into play, but you can find some literature to support you still need some micro scratches in that zirconia to help gain adherence of the cells. So, not sure who that is. About that, guys.
No worries.
No worries, Greg. When you're
Talking
choosing,
to the guy, Bob.
Yeah, I can mute Bob for a minute if you need to take a call. I mean, that's the greatest thing about live stream is it's
whatever
live.
happens.
Whatever happens,
Yeah,
happens.
right.
So you were saying that the degree of polish all comes into play. I think what we realized, and let me go back to my foreshot here, we realized when reading this book. And I don't want to spend so much time on what he says in the book, but there is literature now that's starting to support that some of the best subgingival materials are leaning towards this idea of creating the emergence in the crown with the zirconia. The issue that I took from this in the book was the amount of technical capability that your technician has to have to be able to pull this off, because there is a lot of protocols in what some of the literature is asking for to achieve some of this tissue adherence. So, Greg, you said it first whenever we went to you first there early. You said you have to kind of decide. Maybe you didn't say it like this, but maybe I'm going to put words in your mouth. You have to decide what camp you're in. Are you in the camp that you're going to stick with what we know is strong, which is an emergence of titanium creating a full contour situation with a custom abutment? Or are you going to go back to some of these new newer tie bases that have proper emergence, don't have so much of a flare, can avoid the subcrestal issues of placement of a tie base because of their chimneys now are being custom made from the manufacturers, and you're going to use the zirconia. What camp do you lie in? And I guess for our listeners that I want to ask this is, I think it's important to stress good protocols. In the most ideal situation, right? What am I going to tell my new budding dentist? Hey, single posterior molar implant, number 19, number 30, number 3 and 14. This is what we're going to do in our office because it is tried and true. And I want us to talk a little bit about that, because I feel like there is two camps right now, but you got to have some high-level technicians that can pull off this zirconia.
Well, okay, so I'm going to go back to Bob's statement earlier, because it seems like our verbiage is going back and forth. You can live in both camps. I don't believe in an ideal situation there are two camps. It's one and the same. A tie base can have a customized abutment profile on it. The only thing that's not customizable is the initial height, gingival height before the flare starts, and the flare itself. But then everything that sits above that is actually customized for your patient. And you said it's not the crown that's creating that emergence. You can picture, so let's just say for a posterior we're going to go screw retained. That's, the literature would be very clear that screw retained posterior implant crowns would be the preference, because of contacts opening and because of residual cement. That being said, when you talk about cell adherence, the biology aspect, the preferential material would be zirconia subgingival, not a glazed ceramic, not a layered ceramic. That being said, you can have that, and then on top of it, you could have a crown that is made as two pieces. So imagine you have your abutment that's got your tie base, it's got your zirconia, and then you have a crown that sits on top of that with a hole in it that you bond together. So you can kind of get the best of both worlds. You can have ideal fit, you can have ideal interaction with the biology, and then you get whatever aesthetics you want by whatever material you're going to have as the crown, all made and finally cemented as one big piece. So I don't think, I mean, Bob could talk about the lab side of it. I don't think you need special technicians. I think a well-trained technician is able to do this.
Good.
So yeah, let me build on those thoughts, because if you think about the ideal, which is what we try and think about and what we try and teach, even posteriorly, you've guided the soft tissue with a custom healing abutment, or maybe even a provisional. And therefore, the work of the technician is copying what the clinician has created with the soft tissue profile. The unfortunate part is most clinicians don't take the time to manage the soft tissue posteriorly, and therefore the technician has to try and manage it on their own, and therefore the skill and understanding of the technician comes more into play. But I like the way Gregg describes it, because our preference is to think of always an abutment. What happens subgingival is the abutment. What happens above the free gingival margin is the crown. Sometimes they're made in one piece, right? And so if you're thinking about milling zirconia, absolutely one piece, and you cement that onto a tie base. The other option is you make a traditional abutment that has a prep that sticks above the tissue and an individual crown, as Gregg described, with a hole in it. That might be, in fact, it's my preference anterior or posteriorly, because I can manage things as if it's, if I put the abutment in, now I almost treat it as if it's a tooth. I can try in my crown, check in a proximal contact, check the occlusion, check the aesthetics. If the aesthetics isn't right, I can refire it, I can stain it, I have options. But if it's in one piece, and in this country, most people that make it in one piece have the laboratory cement the components together in the laboratory. And therefore, there is no recovery. If you put it in the mouth and you have a loose contact, there's no way to add ceramic to it because you can't take out the tie base. Where in Europe, the standard would be is use some type of temporary material or something to connect the tie base to the subgingival restorative form. I'll call it the abutment. Try it in the mouth, and then my question to them is, how do you get the parts, get the pieces apart? And they say, well, you can put it in a furnace and heat it up and then soften the cement and take it out. And I said, well, the problem with that is you oxidize the titanium when you do that. And therefore that can negatively affect the fit. And now you have an oxidized surface as opposed to the polished surface. So there's, honestly, at this point, in my belief, there's no absolute protocol that 100% of us are following because we don't have all the answers. And that actually is frustrating for us because as a teacher, we're trying to provide the best answers for everyone in their daily life, but I'm not sure if we have 100% of those answers.
And what you said right there is exactly why we're having this conversation. Because I don't know how many times that through even just our podcast that we get the question of what are you guys going to use in the posterior for your single units? What are you going to use in the anterior? And I like the idea. I think you gave a little bit, you opened the keys to the kingdom just a little bit there, Bob, and how you manage your clinical abutments and your crowns. It gives you the greatest ability whenever you can try a crown in aesthetically on an abutment that's white, right? And work from there on your contacts, your contours, and all those things.
Yeah, everybody knows how much fun it is to adjust contacts on adjacent implant crowns that are one-piece screw retained. It just sucks, you know. And having all that availability.
Even just a single unit implant.
Just one unit, exactly.
One piece. It's going to take a ton of clinic time.
For sure. Yeah, so and the challenge is when you're screwing it in, because of the Morris taper that's on most implant abutment designs, you can't tell if it's 100% seated. You can't take a radiograph and say, well, that's absolutely down. I have flat surfaces fitting together, right? So you don't know if it's a contact that's tight or if it's actually the abutment is tight into the implant. So taking some of those variables out of the equation, I think, increases predictability of achieving the best outcome initially.
Well, plus it has the coolest name, right? Screwmentable. I mean, that's just a word that we need to be using more frequently, I think. I mean, that's just, you can't get any better than that. So let me ask the question to you, Bob. You mentioned that a lot of clinicians don't manage the tissue through to the point of passing that information to the laboratory so that the laboratory has the ability to simply copy the design. And we know there are many methods to manage that we won't dive into because it's a whole different discussion. But let's talk about the typical, which is that labs aren't getting that information. When it comes to trying to determine, say, what tie base cuff height you're going to choose, or how you're going to develop the emergence, what do you think we should be doing? Because we, for instance, we send radiographs along with our impressions so we can show where the bone is at least and somewhat where the tissue is. The more that we're getting into this paradigm of subcrustal implant placement, thinking about soft tissue thickness, we're placing our implants deeper and deeper. What are some things that we can be doing to communicate to our lab technicians about how to make the choices of what cuff height to choose or how to develop that emergence if we haven't worked the tissue out in a provisional?
Yeah, a great discussion and a great question. My first comment would be, how many technicians have been trained to read radiographs? And I think the answer to that is almost none. The higher the level a technician and the closer collaboration with the clinician, you can help the technical understanding in that. I've been involved in, I'll say, commercial laboratories most of my career. And late last year, Gregg and I opened up a new laboratory that in my opinion, it's really fun to be involved in that, because we take what we teach from an educational perspective, and then we see the reality, what happens in daily practices. And so we have the ability to work with a lot of talented people that are passionate and doing the best outcome. And yet, when you look at single unit posteriors, time is money, and everyone's trying to survive in clinical practice being efficient. And therefore, one step that's commonly skipped is managing the soft tissue. So it puts more pressure on the technician to make some decisions on how to make decisions on where you place the collar and transitions and how much pressure to put on the tissue. And my comment is going to be maybe a little bit vague, but in reality, it now becomes case dependent and client dependent. Certain clients will have preferences, meaning that if they haven't managed the tissue, let's say one client prefers a straight pedestal rising up close to the emergence of the soft tissue, and then they have this big crown sitting on top of the ridge. So therefore, when they insert it, there's no pressure on the tissue. That could be one preference, and the laboratory needs to know for that client's, that's the preference. Another client may say, well, 2 millimeters subgingival start diverging this, developing this flare, and I'm okay with a little pressure, but what's a little pressure, right? So it becomes a trial and error, and that's where, honestly, I think the frustration comes into play from a clinical perspective, because if there is too much pressure and you can't get the restoration seated, it's incredibly frustrating and time consuming, and that maybe soft tissue pressure is preventing the proper engagement and seating, and it's going to affect the occlusion and contacts. So the more we clinically skip steps, the harder the insertion process becomes. So technicians, I think, have to interact almost client by client and establish their preferences if they are not going to manage soft tissue intraorally, because there's so many options.
So Gregg, what are you doing clinically?
Well, so let me just build on what Bob said, and then I'll address that. The challenge that clinicians have is there's always a love-hate relationship with your technicians, right? So if your experience when you get your implant crown back is, I can't get it seated because there's too much pressure, you might choose to move on into a different lab, and you would put the blame on the technician for what they did. In reality, the onus should be on the clinician. They're only able to do on the lab bench what you've given them and the information that you've given them. So in the ideal world, the restorative dentist's role is managing the soft tissue on the implant restorations. So at some point along in the process, you would either shape the soft tissue by provisionalizing it, shape it with a custom healing abutment, a customizable healing abutment, do something to start the emergence profile or even make the emergence profile ideal. The more information that you can do and give the technician, the easier their job is going to be. If you're choosing not to, and you're choosing to put all of that onto the technician themselves, now, as Bob said, that relationship is they need to understand what you want, and they need to understand how to get that to you.
Mm-hmm. And you really can't, in the end, blame them. And I think that's something that we, keep reiterating, that we can only expect back from the laboratory what we guide them to give us. And I know it's not maybe as popular in the world of fast-paced dentistry to work through a posterior implant provisionalization, or even just customizable abutment. But, again, without diving too deeply into those things, there's a lot of options today. Especially if you're placing your own implants, it becomes a little easier. If you're working closely with the surgeon and the surgeon's willing to do just a few things differently, if you have CAD CAM in your office, there's a lot of ways that we can start developing that early. And of course, in the anterior, you'd be silly not to do it every single time. In the posterior, the communication is critical. And so when we talk about this tie-based issue, we didn't put this in the question in the show before, but we were at AAFP, American Academy of Fixed Pros, and this occurred to me. So we're talking to Ronnie Young from Zurich, and he said something that we had never heard before, and I just want to maybe get your take on it, because it could be completely off. He goes, you know what we're studying? And he's very intense. He's like, you know what we're studying? He's like, tie bases are completely unproven. And we were like, what? And he said the idea of cementing a crown extraorally onto a titanium base or a custom abutment, whatever you want to call it. He's like, what's going on at that cement junction in the mouth? He's like, because we're so anti-cement, but then we're cementing these things. And he's like, we're worried about that. Are you guys worried about that at all? Do you think there's anything to show that we should be concerned about extraorally cementing these things and putting them in? Have you seen any data on that, or is this just something that maybe is nitpicky?
Well, I think the point taken. Too oftentimes in dentistry, we do things without any real research. And I recently heard Young speak, and I heard him talking about this, and I think he maybe has some valid concerns, right? We're doing things just because it has driven the costs down compared to, for example, a UCLA concept, and that's been around since the 80s. And yes, we know today that we try to avoid casting alloy because maybe it can corrode, and if you have fired ceramic on it and it's subgingival, it tends to be rougher and more porous, and it's not great for not only adhesion of the cells, but also plaque retention. So we're looking at, because of CAD-CAM technology, ways to customize the subgingival form and to get away from a zirconia connection to the implant, which we know has a high risk of failure. Now a titanium transition makes common sense. But yet, we don't have any real long-term clinical data to say this is the right thing to do. And I hate to say this, but if you take a pessimistic view and you look at 5 years from now or 10 years from now, if 90% of these things fail, we have a real problem, right? Is that going to occur? Is that going to occur? I don't know. I mean, I would love to believe it's not going to. But if you look at the original designs in some current designs on some systems, where the chimney in one system in particular is maybe 1.5 millimeters tall, and you rely on the screw to diverge the metal components so you don't rely on cement, it's almost going back to the original Brandemark design, where you have the external heck that's extremely small and you rely on the screw to hold things together, and we've realized maybe that's not the best thing to do today. So the taller the chimney, the better. But now the point is, we have a cement layer that could be closer to bone, right? Depending on where your flares and so forth. And is that a concern? We don't know. And I think that's where Young is just trying to say, we don't have the answers. And as a research person, I think that's an honest appraisal of the situation. We don't have the answers. So one of my favorite statements is, you have to go into things eyes wide open. If there are problems, maybe we can't blame someone else. We have to always look at ourselves first, and maybe we shouldn't be doing things if we don't have the research to support what we want long term.
Gregg, any follow-up on that?
Well, I think I think that Young has a good point, because if you just look at the evolution just of a tie-based concept, we had problems, right? And there was a response from manufacturers. So we go into it thinking that we have knowledge and we use them, and all of a sudden the tie bases are too short. The flare comes off too shallow. And so we end up having problems. Those are immediate type problems, right? They happened within the first year, maybe even sooner. And I think what Young is talking about now is we don't have long-term data on this. We've fixed some of the structural issues that we saw, but we don't know what's going to happen long-term. And he's absolutely correct. I mean, time will tell. The only way to see what's going to happen is just to start watching, because there's so many of these, probably the go-to material in restoration choice now to do these tie bases, because as Bob said, it does keep costs down, which has always been a challenge in the implant world, is that costs are raised for the patient. And so either the clinician loses out because the additional laboratory fees. So it'll be interesting to see. I mean, hopefully what we're doing has validity and will still maintain health and structural stability over time, but it isn't there yet.
Right, because it's either that or going back to like a one-piece milled zirconia, connection to the implant, which, as Bob just said, it doesn't make us feel great either. But that was almost what Young was kind of pushing toward. He said, "I'd rather have that." He made that statement. Now, again, I think he was being a little provocative. But he was, trying to say that that's how little we know. Like, at least we know what a one-piece zirconia connection is and how it kind of works because we have data. So anyway, interesting topic. And Wes, let's...
Yeah, we've been talking a lot about single units, and I think it's important to kind of move into this next thing, which is multiple unit restorations. And I see myself doing more multiple implants. For instance, say a patient they lose 18, 19, and 20, and or maybe they've got a situation where it's going to be an optimum situation versus placing 3 implants. Let's place 2 and bridge. Now, in the past, my training back in 2001, 2002, in the early days of my restorative training, I remember, we called them second stages, and you had stages upon stages of abutments, and it started to get into this layering of prosthetics. Today we use what we call multi-unit or transmucosal abutments, which is a stock abutment that goes onto the implant, and then this creates a interface that we can restore multiple implants in an arch and have a nice draw or fit, which really gives us the ability and restorative flexibility to do full arch restorations, 3, 4, 5 unit prosthetics, and it's a screw retain restoration. Now, the interesting thing is that as we start stacking those things, restorative space becomes a problem. And that's where John and I really started looking at how can we, based on subcrestal implant placement, right, which is where we're at right now most of the time, and these internally connected implants, how can we get away without using the transmucosal? And one of the suggestions in zero bone loss concepts was to use a non-engaging tie base, maybe even keep an engaging tie base on one of the units for restorative flexibility and being able to seat it to have a path of insertion, and then cut off the hex on the other one. Is this a feasible thing to move away so we have more vertical dimension, to move away from transmucosis?
And not having a secondary tiny screw also, right. I guess, if you move. Yeah, what do you guys think about that approach?
Right.
Yeah, so a couple of comments on that. When you stack as you were describing it, in my opinion, the weak link becomes the tiny screw that you're using to connect those different components. So I think you're at a higher risk of failure because of the small screw you're using. But then going to the non-engaging concepts, again, that's nothing new because that's what has been done in the infancy of implant dentistry and restoration when you're doing bridges, because virtually never are they perfectly parallel. So you would have to go to a non-engaging type concept. So it's new for the tie bases, of course. Some manufacturers make tie bases that are non-engaging, others don't. And as soon as you touch that tie base and cut off the hex or the timing aspect of it, you void the warranty on that abutment. So there's multiple things that come into play, but logistically, things have to play out that way in order to do bridges, because, like I said, virtually never are they implants perfectly positioned, and you have a common path of draw that you can actually get the components to engage. So honestly, I like that direction as opposed to stacking abutments and going to the smaller screws. But it depends on, of course, the clinical situation, but that would be my preference.
Absolutely. I think there's a place for both of them. And in my practice, the way I would think about how to choose one or the other, the benefit of this abutment is you can put it in and you never have to have connection and reconnection. So I don't have to pull it on and off every time I want to do something, because I'm working at tissue level as opposed to fixture level. So you have the health of the tissue right there, because you don't have it, detached and reattached. I don't use them a ton until I have multiple implants. So multiple meaning I have 3 or 4 implants that I start to have to get things to be fitting on them. Then the multi-base to me starts to make sense. 2 implants, 3-unit bridge, 4-unit bridge, whatever it might be. I think staying in our traditional realm of, yes, one hexed engaging and then one non-engaging, and being able to stay with our traditional materials. I still have all of that made as separate abutments for the same reasons we talked about the screw mentable. But now the additional benefit of doing that is getting passive fit, because there's really no tolerance on an implant restoration. So if I can get the implant abutments down and then I can try the bridge on, I can bond the components in the mouth, now I have pure passivity of fit, which is going to be hard to obtain without doing that, because of the inaccuracies of stone that sets and materials that are milled or cast or whatever it's going to be. So give me multiple implants and then I'll go to the multi-base, but just give me a few implants and have me splint them together. I would still stay with our traditional methods.
Now, what do you say to somebody who asks the question or raises a concern, but if you're using a non-engaging cylinder or non-engaging connection for a bridge, you're not engaging that connection and that stability. They're concerned about the stability of the joint. Do you think that is an issue at all? The fact that we have these great connections and yet we're not engaging the hex. Is that an issue as far as things like bone stability, micro movement? Is that something that you get at all concerned about? Or is that something that really we go back to our external hex days, which we were doing that all the time, and it was the anti-rotation and the passivity that we relied on?
It's a great question, and I'm not sure if we have the answers, because there's so many implant restoration options today. Staying within a brand and then going off label, and you look at the precision of fit, but some research will say that the Morse taper takes the load as opposed to the hex, but the hex gives the timing. And they say that looking at a radiograph, there's a space between the actual implant and the hex. Well, that can't be true, in my opinion, because then the timing would be irrelevant, because there would be so much slop. So that doesn't make sense. But is the Morse taper taking the predominant load? I'm not a scientist. I haven't analyzed it, but it makes sense to me. But there's so many different designs. I can't generalize on that. So if it's non-engaging, and this is interesting, I just encountered this yesterday actually in the laboratory. A client had 2 Astra implants to do a 4-unit maxillary anterior bridge. They were 3.6 implants, and they were slightly divergent. And now the thought is, how do you manage that situation? And they wanted to go screw retained. There is a screw retained option for that small implant, but it's only in titanium, not in zirconia, and there's no tie base option. And in order to custom make that, you have to have timing on that implant. You can't do it non-engaging. So again, that creates tons of technical challenges that, I mean, we don't have time to discuss, but the more you do in implant dentistry, the more you start realizing all of these complications come into play from a laboratory perspective. So could you use the engaging part and design it, make it, and so forth, and then cut off the hex? So it allows that path of draw to occur. The answer is yes, and that may be the logical solution. But if some clinicians want to stay within a manufacturer's line of all of their components, and as soon as you cut off the hex, you void the warranty, and if there's a future problem, then what do you do, right? So again, reality comes into play when it comes to manufacturing of all these components. When I say manufacturing, from a laboratory perspective.
You know, one of the things that's interesting as we're sitting here talking about it, because I don't think people realize until you really start diving in and restoring multiple cases how important the surgery is, because it can impact you. Just a couple of degrees can impact you and negatively affect and actually cause what Bob was actually just talking about. Astra implants have a Morse taper. It's 11-degree internal taper. And John, we actually deal with an implant that even has a steeper, right, internal connection. And just those things, understanding those things as a restorative dentist and communicating that to the surgeon that this has to be.
It's even changed for Wes and I. We had this discussion about a year ago because we were using this really nice, super tight connection Morse taper implant. But if we were doing multiple units, we're like, we don't want to use it anymore because it's a problem once you get into multiple units of having to use multi-unit abutments. And that's fine to use them, like Gregg said. I mean, they have their place. But if now you're adding cost, you're adding height and vertical issues. You have more components you're messing with, and
this altered
tiny
screw
screws.
access, altered screw channel that he's talking about, John. It's cool,
right?
But there's a lot of little intricacies.
JPD paper, just altered screw channel access. You get 80% fractures, right, happening once you go over. I think it was 20 degrees or something. So I think that we told our surgeon, hey, if we're doing multiple units, I'd almost rather have X hex. You know, not necessarily X hex, but more freedom, so that we're not hemmed in by these great implants, but they kind of sometimes hurt us a little bit. Let's change, because man, this is awesome stuff. Let's change topics again into.
Let me just add one thing, because we begin of the implant workshop and the implant seminar, and we begin them talking about implant positioning. And I always think, man, we're really, we shouldn't be doing this. This is like so freaking basic that why am I spending time with the positioning of implants? And the reality is, you guys said it, it is probably one of the most important things, because it will, just being off a touch will dramatically change our ability and the ease of which we're able to make the restoration. It'll change material selection. It'll change design characteristics. It'll change from cementable to screw retained and vice versa. It is so important about the implant position, but I think a lot of people just go, well, yeah, we got that. I can get it. I get it close for you. But it makes our life really rough. So we start every workshop and seminar the same way. And I'm always in the back of my mind, they're thinking, surgeons in the audience are looking at me going, really? we're going to really talk about. But I can't tell you how many times, and again, you could say if you're not a trained specialist and you're placing implants, maybe you should really pay attention. But the reality is, I don't think that's the statement I would make. I see implants coming back from trained surgeons that I have significant problems with because they've got it already. So it's really an important aspect. I mean, that's not our aim here because Bob and I aren't surgeons, but it is an important piece that should always be discussed.
Yeah, and the surgeons often don't see these struggles that we're talking about ever. They just don't understand oftentimes what we're dealing with. I think it's easy to criticize, say, dentists that get into placing their own implants from a surgeon standpoint, because you're thinking maybe it's a territory issue, and sometimes it is, and there's some legitimacy. You got to be doing it right. But I think there's also some people that go, man, like I got to do it because I got to have more control because I'm running into so many problems, and I don't think there's some legitimacy to that too. And it is interesting. I still find it so interesting that the better our implant connections get, it's like the more problems we kind of have, with some of these things. And the deeper we're putting our implants in, because we're understanding things, adds another layer of 1 degree off, 2 millimeters deeper becomes so many more degrees off as you extrapolate that angle. So one question comes up a lot when we're talking or teaching or whatever is the challenging case of small abutments in an aesthetic area when we don't have, either because of non-ideal implant placement to facial oftentimes, or because of just small restorative space. We end up using a small abutment because of the space issue. And the question of material selection in these cases, when we have, say, let's choose a maxillary lateral incisor, which is a common area we're working in, and we have a small space to begin with. We often have, as we sometimes say, the devil horn shaped abutment, where the entire middle of the abutment has been carved out to make room for the screw. We get to where we're oftentimes looking for high translucency in our final restoration in these cases. Talk through how you guys decide what material choice you would go with there. Do we take the chance on zirconia in some of these thin, small abutments selections? Do we look at opaquing titanium? Do we drop back to PFM? What are we thinking about here in selection? Gregg, maybe start with you, and then we can talk about Bob and talk about from the lab standpoint as well.
I think the first thing we need to realize is when we get into these smaller diameter fixtures, options are pulled off the table without even, it's not even a choice anymore. I think a lot of these smaller implants, they don't have zirconia as an option because the zirconia is going to be too thin and it's going to become too weak. So then going back to the implant positioning, that's paramount now. It's even more important for the implant to be positioned correctly in those situations. But if you pull then zirconia off the table, now you go, what do you have left? The example that you gave is we have a translucent situation. Well, if we have translucency, then zirconia gives us a nice aesthetics and strength. But if we can't do zirconia, what else do we have? I think you then have to go back into either a UCLA kind of option, or we can buy stock titanium components and use them as a tie base, because again, a lot of these don't have tie bases either. So we could go with a stock titanium abutment that you would buy out of the catalog, and then you could customize something that goes on top of that. So the stock piece becomes your tie base, and then you could use zirconia and then bond those pieces together, either as a cemented crown or a screw retained crown. So I think that's kind of the position that we have to go to when we start losing some of these other options.
Gotcha.
Yeah, I think Gregg covered that nicely. It's hard to generalize. It's case dependent, implant position dependent, and then the trying to evaluate the space requirements for strength and durability, not just for aesthetics. Aesthetics is always the icing on the cake. So you always want to have a situation that you have I would get a predictable long-term outcome, and that means in the mouth 20, 30 years, let's say. So you don't want to compromise strength of that substructure or the abutment. And this is the challenge that we face in the real world dentistry. We may not have those answers. In fact, traditionally, we don't have those answers until we have the final impression that is in the laboratory. We have the final master cast, and then the decisions have to be played out. What are reasonable options? So it's nice to go into it with a really clear plan at the beginning, but sometimes we don't have those answers until it gets in the lab. And it's a little off topic, but the cost variances can be maybe significant depending on what option you have to go to. And that's where I think most clinicians have to be thinking about that in treatment planning and discussing outcomes with the patient and fees associated with a case. And you may have to give a range of fees for the laboratory side of things, because we don't know if it's got to be a UCLA or can we go to just maybe an option of all zirconia stock abutment that's shaped or modified, right? So we don't necessarily have all those answers until the time of fabrication of the restoration.
So, kind of in summation here, we've talked a lot about, just abutment selection. And I think if you're listening to this and you're thinking, whoa, there's more to implant dentistry than just putting a piece of titanium in somebody's jawbone and taking an impression. And one of the things that I think that I began to appreciate, and it wasn't probably until I was into practice and had done this long enough, was that first, I recognized that taking an impression for a dental implant restoration was maybe one of the easiest things that I did in my day-to-day routine. But what I didn't really appreciate until I had actually seen enough and done enough was how complex it becomes the more you involve implants in your practice. And people ask us, and I'm going to say this all the time as we close out the show, is if you're wanting to get into dental implants, my advice and John's advice has been all along, and I want to ask Gregg and Bob their advice. My advice and John's advice has to do with if you want to start placing implants or even restoring implants, before you even place, you need to understand restorative componentry and systems. And you have to actually be a doctor, right? Because sometimes I feel like that we're not the doctor, and I'm gonna be a little hard on us, and we rely on other people, the lab tech, to share their knowledge. And there's some great lab techs. We have one that we use that knows so much more than we know about certain things, and they help us. But it's our turn to kind of step up. And my advice would be, if you're wanting to learn more, go out and get an amazing amount of restorative knowledge when it comes to dental implants before you just dive into it.
Yeah, and that's what you guys are doing out there at Spear. I mean, talk about that, as far as what you guys are teaching, and kind of along those lines, what the value of the restorative understanding for obviously the restorative clinician, but also for the surgeons, because I know you guys teach a lot of surgeons out there too about restorative techniques.
So one of the things that I always take from my surgeon. So Jim Janikowski is a periodontist here in the Northwest that I work with, and Bob works with as well. And when he was actually full-time faculty at the perio grad program at Washington, he would walk in and the grad students would all want to be, just chomping at the bit to place implants. And he would give them the PROS manual. Here's the PROS restorative manual. They're like, no, we're perio grad students. But he would say, you need to understand what you're doing now and how that's going to impact the restorative dentist. And so it's that whole restoratively driven treatment planning aspect, and it really plays out with implants. And so in our implant workshop that Bob and I teach at Spear, We typically always have surgeons in the room with us. There's 2 to 3 surgeons in each class, mainly restorative dentists. But the way it's designed is to get you, as you all said, is to get you to think differently about implants. It's not just screwing something on, making an impression, and then here, give it to the lab and they'll determine it. There's so many more nuances that we as restorative dentists need to take into consideration and own ourselves to make our outcomes better. It takes more time. There's more steps involved. That's why the fees typically are higher for an implant crown, because I have to do more work on the front end if I want the final result to be aesthetically and structurally predictable long term. So Bob does the hands-on exercises in that, and there's I think 18 exercises, Bob, isn't that correct?
Approximately.
So there's a lot of different things. Go ahead.
Yeah, we go through a lot of different techniques to do different things, and it's the implant restorative workshop. Impressive, I think, to many restorative people in the room. It's all about tissue management. So the key is tissue management to do the restorative things. And when the surgeons take the course, because they're doing that predominantly because the expectation is the restorative person wants someone else to manage the tissue, and that becomes the surgeon. So it's not about the crown anymore, whether it's a veneer or crown on a tooth or a crown on an abutment. The crown's a crown. It's what we're doing, managing the subgingival tissue is the key from a restorative perspective, and that's why we believe so strongly in the aesthetics zone for sure. We manage soft tissue, but posteriorly, it's equally important, and it may seem like you invest a little bit more time to manage the soft tissue posteriorly, but it solves and prevents lots of problems from the insertion time and predictability of that whole process. So a little investment of energy up front pays off in aces in the long run. Awesome. And one additional comment about Jim Janikieski is one reason he's such a great surgeon, and now we're talking about implants, is he was a general dentist before he went to perio. So he did live the reality of the restorative side of things. So he's thinking as a restorative person, not just as a surgeon. So I appreciate Gregg's comments about, the surgeons want, how do I place the implant? Well, you have to think about the restorative side, because that's ultimately where the ball lands, right? Is how we have to manage that.
Yeah. And truly the most successful, even financially, surgeons, I know that's not what it's all about, but it's interesting, that I've ever known have almost always been the ones that understand the restorative to the nth degree, because if you understand that, you're putting things on a silver platter for many of your restorative doctors, and you're giving them such a heads up that they want that. They want more of that. Now, I understand doesn't get us off the hook as restorative docs. We still need to be driving that. We should be taking more responsibility for that. Wes and I are such big believers in that. But as a surgeon, if you can set up your restorative doctors by saying, hey, I've just been thinking about this case. I got a couple restorative ideas on this. What do you think? That's you're going to dominate your area. Yes. I wish we had more surgeons that were going out and taking this workshop, because that's what helps our restorative docs. The reality is that unfortunately, you guys are working on all of this, but you're trying to get everybody up to the higher level. So, this has been a great show. I think we need to come back. I personally think we definitely need to spend some time more on some subgingival tissue discussion, especially in the posterior. Would love to have you guys back to talk about that. But if you've been listening to this show and you kind of have taken some of this and you thought, man, I've learned some things today. Where can I learn more? Head over to Spear Education, check out what they're doing. And I think you'll find that they're going to offer, from a surgical and restorative standpoint, the best integration, or some of the best integration of those two things together. Also, go out and check out what we're doing over at the demos, and like, subscribe, and share. Give us a great review on Apple Podcasts. Would be amazing. That really helps us to get our message out. So we really appreciate everybody that's listening today, both from the Spear Education side and the Dental Guys side. We look forward to bringing you more great content in the coming weeks. So for Bob and Gregg and Wes, I'm John, and we are the Dental Guys.